For those of you who haven't been here before, I'm Dr. David Rawson, founder and president of this academy, Canadian Academy of Clinical Sleep Disorders Disciplines, CACSDD for short. It's my pleasure tonight to welcome Dr. Mark Murphy, who lives not far from us in Michigan, but you'll find out he has a vast wealth of Canadian geography. He's been in Canada many times and has lectured in lots of centers. So he is an honorary Canadian tonight. And his topic is minimum effective therapeutic dose in oral appliance therapy. Mark is a principal of functional consulting, lead faculty for clinical education at ProSomnus Sleep Technologies, serves on the guest faculty at the University of Detroit Mercy School of Dentistry, and as a regular presenter on business development, practice management, and leadership at the Pankey Institute. He has served on boards of directors of the Pankey Institute, National Association of Dental Laboratories, the Indoloid Council, the Foundation for Dental Laboratory Technology, St. Vincent de Paul's Dental Center, and the Dental Advisor. He lectures internationally on leadership, practice management, communication, case acceptance, planning, occlusion, sleep, and TMD. And he has a knack, and I know you'll find this very quickly, for presenting pertinent information in an entertaining manner. Without any further ado, welcome to Canada, Dr. Murphy.
Thank you, David. Appreciate it. I do have a great familiarity with Canada. Been to every province but one, and I feel like I live in a little suburb, a little town about halfway between Sarnia and Windsor. It happens to be in Michigan, though. As many of you know your geography well, I was quoted earlier. We go south if you're in Detroit to go to Windsor. And I just love bringing people to the city and having to look south across the river and seeing Windsor, Canada. And they get very confused because they think of Canada as so north of us and everything like that all the time. So you've got my email here. So if there's anything you need, a copy of the slides, information, data, information about ProSomnus, et cetera, feel free to reach out to me after the webinar. I'm going to try and go fairly quickly because I think the Q&A section probably will have some robust opportunities for good conversation. So let's go ahead and jump into the slides and have a little fun with that. Therapeutic dose, minimum therapeutic dose in oral appliance therapy. And what does all of that feel like and mean to you? Well, the first thing that came to my mind is I thought about a game of chess. And I thought about how sometimes when you move one part, it impacts how these other parts were going to play. And I thought, wow, that's so true in oral appliance therapy, because you've got things like you're trying to get a certain type of an outcome or result from the treatment that we're doing, but there's all kinds of things like some devices, some treatments have greater efficacy than others. Some require a higher dose. Some patients require a higher dose. Some patients are non-responders. There's different ways of taking the bite, titrating. And I'm like, holy cow, there's just this large matrix that's intertwined together very intimately that impacts all of the kinds of outcomes that we're trying to drive. And dose management is part of them. But if I just segregated out dose and talked about how much we advance the mandible, how much we titrate, how much we dose the patient, I think it would be disingenuous to the treatments that we're trying to render. David and I have had wonderful conversations about bite relationships, and we've talked about phonetic bites, and we've talked about pharyngometry, acoustic pharyngometry. We've talked about Matrix Plus. I'm familiar with that, remember stuff, and the George gauge, airway metrics. There's so many different ways. And yet, we get outcomes from all of those different types of bite relationships. So now it's really a way of how do we maybe start to really create another layer of science on top of what we do in oral appliance therapy to try and control the dosing for the patient. Why? Because there'll be fewer side effects, or there'll be more manageable side effects. We maybe can improve the outcomes, patient comfort, et cetera, efficacy, compliance. So it's a really complex set of things to think about. So I'd ask us, like I think you would do in chess, like hopefully you do in your practice or in life, to begin, as Covey says, with the end in mind. Where are we trying to get to? What are we hoping to accomplish? Because if we keep our eyes on the prize, then the next step we take, we should be able to align that with the goal and objective of the particular outcome we're trying to achieve. So it was interesting because the program I sat in on and listened to a few weeks ago now was talking about phonetic bite registrations, and there was a great deal of data, David. I really thoroughly enjoyed that. I love it when somebody has data to present and talk about. So let's play a little game here, and let's just set a baseline. And you can like my baseline, you can not like my baseline. We could argue about what percentages and numbers you want to have. I'm good with that. But that's not going to be the point of this evening's conversation, because we're really trying to focus on the dose end of this whole conversation. But let's jump to the end for a second, and let's pretend that I'd like to get my patient down below 5. Especially in the States here, getting somebody below 5 is a golden result. If we talk about CPAP, and we'll talk about CPAP later as a gold standard, the gold result that we'd like to achieve is below 5. And we know that we're not always going to get that, especially with somebody with a high number, especially with somebody that maybe has a large BMI, somebody that maybe has some non-responsive characteristics, whether it's high loop gain, whether it's pharyngeal dilator muscle activity, whether it's a low threshold sensitivity. There's lots of other things. So we might not be able to get it, but we might be able to create some significant reduction. And so 50% is commonly used as a reductive number, or getting them below 10. And I know that really all of the physicians I work with are happy with below 5, and all of them are happy with below 10 and a 50% reduction. I'm sure there's some who'd be happy with below 10. And if I started at 14, below 10 is still a reduction, but I'd love to get it 50% and below 10. So for today, let's use that the end in mind that I'm targeting with my physicians, and that I'll show you in my data, is an AHI below 5 or below 10 and a 50% reduction. I also want to reduce and eliminate some of the subjective signs and symptoms, because it's not enough to drive the AHI score down. There's huge discussions in the literature today, and in medicine and in dentistry. Is AHI the right metric? What about RERAs? What about ODI? What about quality of life? It's not a simple objective number that we hit and we say, wipe our hands, everything's done, the patient's fixed, everything's great. It's not. We want to be able to improve the readiness, for example, of a police officer, of a soldier, of a truck driver, of somebody that's in the transportation industry. We want to eliminate subjective signs and symptoms. We want to get couples back together in a bed. We want to have people not be tired during the day. There's so many ads on television about these new medications you can take to keep you more alert during the day. And I'm thinking to myself, I think that's the wrong way to treat sleep apnea. So I want to reduce subjective signs and symptoms. I also want the patient to be compliant or adherent. When those words are somewhat interchangeable. So I'd like them to wear the device every night, all night that they're sleeping. So 7 hours, 7 nights, 8 hours, 7 nights. I don't care what we do. But the CPAP metric of 4.5 hours a night, 5 nights out of 7 is woeful. It's woeful. And so if I'm getting them to these numbers and I'm eliminating the subjective signs and symptoms, and they're wearing it and very compliant, but they have horrible side effects, we still lose. If you take a pill for hypertension that causes your hair to fall out, you might say, I'm not going to take that pill. Every time I take that pill, my hair falls out, or it makes your stomach sick, or you lose the ability to walk, or something like that. It would be crazy to say the side effects are worse than the disease. And so I'm not suggesting that the side effects in oral appliance therapy are worse than disease, but I am suggesting that we've got to look at all of these factors when we think about this end game, when we think about the goals and objectives. I want to have the least dose that I can of any medication, of any treatment regimen, of any therapy that's effective at reducing the disease state. I want to have that patient be able to adhere or comply with that therapy. And I want that patient to be comfortable in that device that they're wearing, in the case of oral appliance therapy or a knee brace or any other durable medical equipment. And I want to drive significant improvements in the outcomes. And we certainly use the term mean disease alleviation for that quite often. It's a good catch-all term. And I'd like it to be with minimal side effects. All good. So mean disease alleviation is going to be a very important metric for us tonight. We'll substitute some terminology like effectiveness, and we'll feel that difference between efficacy and ideal situation and considerations versus effectiveness, how well that therapy works in the real world. And we'll see how well that is impacted by dose, by compliance, by all of the different things that hit it. And it's important because we know, for example, from McAvoy's SAVE trial from the New England Journal of Medicine back in 2016, that CPAP might not cause enough disease alleviation in a population to be an effective choice of therapies. That's incredible research. They took a population of over 2,600 patients, and every other one got CPAP, and the other one got nothing. CPAP, nothing. CPAP, nothing. CPAP, nothing. Did that, followed those people for for 84 months, 7 years. And then they tracked cardiovascular events in those two populations. And you can see by the two graphs here, those lines are nearly identical. Now, you know, and I know, that inside the line that was treated with CPAPs, there are some patients who wore their CPAP every night, 7 nights a week, 7 hours a night. And those people most certainly would have had lower cardiovascular events. It turns out when they dug back into the data after the clinical trial was done, they did find that. So what does this study say? The study says that if you give 1,000 people a CPAP, because they won't wear it very much, because there's poor compliance, even though the efficacy is very high, the efficacy times the compliance or times the adherence means it does not have a definitive, significant mathematical improvement of a cardiovascular incident rate in a population. Now, before you think about what all that means, what was just published a week ago today here in the States by the Agency for Health Research and Quality that was requested by the government service, Medicare and Medicaid Services, the Centers for Medicare and Medicaid, it's called CMS. They published a study that says CPAP doesn't work. And this is pretty interesting because the Center for Medicare Services is saying we shell out millions and billions of dollars. It's a $4.5 billion activity in the United States, and oral appliance therapy is about 100 million. So think about that for a second. We're about 4 or 5% of the oral appliance or of the OSA market. $4.5 billion. And they're saying most of that is going right down the toilet because as you look at that study before, the conclusion is the studies and the validity of AHI may not be an accurate metric for treating obstructive sleep apnea. And the evidence shows, specifically with low, certainty of evidence, low specificity of evidence, randomized controlled trials do not demonstrate that there's been an improvement in cardiovascular outcomes. When non-randomized controlled trials were combined with that, they got a tiny bit of improvement, but with a low certainty of evidence. So when you have low evidence in these trials, what's happening is the Medicare service people are saying, we're going to quit paying for CPAP. Now, that's going to be like an earthquake here in the United States. So this paper is not out as a position that's going into law. It's out as a statement from the AHRQ that says, here's what the Medicare services ask us to look at. We've looked at it. Here's what we found. And it's a 155-page report. It's available online. And based on this, you can imagine that if you're an insurance company, if you're a government agency, or if you're anyone who's paying for CPAP, you would say to yourself, why the hell am I paying for CPAP? I'm shelling out billions of dollars for CPAP, and it's not improving my patients' health outcomes. Well, this is a real challenge for us because we can look at that and say, obstructive sleep apnea treatment is dead. Or maybe we look at it and say, what an incredible opportunity for oral appliances who have not nearly as good an efficacy as CPAP, but excellent compliance and adherence. Maybe it's a time for us to shine. And it reminds me of the story of a shoe company that sent 2 salesmen to Africa, one to the East Coast, one to the West Coast, and said the CEO of the company sent the 2 sales managers down and said, listen, go to Africa. There's a lot of people down there. And let me know if you think it's a good market for us to get down there and sell shoes. So the 2 salesmen came back, and the first salesman came in and reported to the CEO, horrible place to try and sell shoes. He goes, why do you say that? He said, I went down there. Nobody wears shoes. We couldn't sell anybody a pair of shoes down there. CEO says, okay. The other sales manager walks in his office and says, what an incredible place to sell shoes. He says, why do you say that? He says, because nobody down there has any shoes. We could sell everybody's shoes down there. My point is 2 people can look at the same object and see it differently. We've all done this. 2 people can look at the same problem and see the problem differently, see the solutions differently. It's really about the paradigm with which we look at something. So I don't think there's ever been a better time to be thinking about the role of dose, treatment, and adherence as variables for driving mean disease alleviation. So let's first take a look at dose, and then we'll add a little bit about treatment, device selection, and all the different efficacies that those present. And then we'll look at compliance and how that impacts dose and treatment and mean disease alleviation, because these gears are all turning together in this chess-like matrix that we talk about. Well, in medicine, in drug therapy, and pretty much everything that anyone would be doing out there, there's this idea that there's a therapeutic drug dose at which you get a therapeutic effect, comma, and if you continue to administer more of that drug, you'll eventually get to a toxic effect. Okay. And there's some people who don't respond at the lower doses. Okay. And there's a range or a window in which the dose is adequate to create a reduction in the disease state and yet not have significant side effects, or as they usually talk about with medicine, toxic effects. And you can see that there's sometimes incredible sensitivity. For example, when they halted the J&J vaccine recently, it was for a very small 0.01% incidence, a very, very low percent of blood clots. And so when there's a new drug, when it's relatively untested, we're shelling that out to hundreds of thousands, millions of people very quickly, you're always going to be just a little hyper vigilant on that. It's not like we have clinical trials that lasted 2 or 3 years. This was an Operation Warp Speed where we got up and running with vaccines in very, very short time. It's amazing how the world responded to that particular challenge. But it's this idea of balancing therapeutic effect with toxic effect. So let's think about that in a little broader sense. If I have a drug, if I have an advancement of the mandible, if I have a repositioning three-dimensionally of the mandible, let's think of it that way. If I can find a position of the mandible three-dimensionally that is effective at opening the airway, reducing the AHI score, reducing all of the subjective signs and symptoms we talked about, that's fantastic. And we know we can do that. We also know we can't do it on everybody for a variety of reasons. Some people are non-responders, and we talked about some of the reasons for that. Some people we just can't mechanically, because most of the result is mechanical. For some of the people, we can't mechanically pull their mandible far enough forward or open into a three-dimensional position that offsets maybe their BMI or the size of their tongue or the size of their bony box or the range of their mandible. There's some mechanical limitations. And then there's some people for whom they maybe have some mild side effects that we manage, like people get up in the morning sometimes and their bite feels a little different. It's a side effect. We know we can recapture that. Some people get up in the morning, and sometimes when I get up in the morning, I'll have just a little bit of sense of stress and strain, but they're easily managed side effects. Some can be a little bit more seriously managed. And maybe if we get transient bite changes that we can recapture, that's great. But if they become permanent, and the intervention and the management can become a little bit more significant. Similarly, if there was tooth movement and it had a very minor impact, but maybe an intervention that I had to have a restoration replaced because I had developed an open contact and I was catching food, or I didn't like the aesthetics of some tooth movement because I'd used a flexible type of device or something. So you can see how, again, there's this balance to the different degrees of side effects or toxic effects of the dose that we're being given. And then certainly there's the opportunity that if the side effects are severe enough, just like the hair falling out or inability to walk, whatever that might have been, the patient might discontinue treatment. Interestingly, I run, as you're going to see soon, a tremendous amount of data. ProSomnus loves me for that, and they do a nice job of paying me handsomely for running data on all my cases. But in the last 4 years, I have not had a single patient who discontinued treatment, because of a side effect. We had patients who we didn't continue treatment with them because we could not get enough mean disease alleviation for them, and we sent them back for CPAP, or we had to add other therapies or other treatments for those patients. But I had not had, until just recently, a patient who I could not find a comfortable position for a mandible, could not find a comfortable enough position that she could continue in treatment. And so she became one of a very, very, very small percentage of discontinued treatment because of I could not find a dose to advance her mandible that was comfortable enough for her to not have a discontinuing side effect. We did get tremendous therapeutic result for her. Her AHI score came down. She felt more rested, but she was in pain. And so we worked for quite a while trying to work that out. But you can see how when we talk about the efficacy and the effectiveness of things like this, we know that it's not going to be 100%. And in dentistry, we're so used to fixing every tooth and every tooth problem that comes to us that sometimes it's very, very challenging to think that, no, I don't have the answer for that one. Well, it turns out this is a poster that will be published at the American Academy of Dental Sleep Medicine meeting soon, the end of the month. And it's interesting because we took a case series. I think it was 50 in this one. We've got, I do them in chunks of 50 as I do these reports. And what we did is I have a particular bite registration technique that has been very effective at me, and it's using a little bit of a snore test and trying to find a three-dimensional position for the mandible. I'm using a lot of thinking about horizontal and occasionally some vertical addition to this. But what was interesting is when we took a look at the dosing of this, we realized that the average patient that I was starting, we were starting at about 50.3% of the range of motion. Now we were getting 74% overall reduction in AHI score, 74% reduction below 5 or below 10 and below 50%. So we were getting a very high efficacy and an extremely high, nearly like 96 or 97% compliance. That's not contained in the dose poster, but we were getting very high compliance adherence. We're getting better than what's normally reported in the literature for oral appliance therapy. And of course, we would attest that too, that I was using in this particular series exclusively ProSomnus devices. They're designed with artificial intelligent engineering. They're used robotic manufacturing and milling so that we can make them smaller, stronger, more tongue space. Smaller, more tongue space means, let me think, maybe less dose. And so it was kind of interesting as we started to postulate, well, why did we get such a significant improvement in AHI scores and subjective side effects with 50.3% starting position and 1.29 average protrusion from there? 36% of the patients resolved at the starting position, 0, at 50.3% on average, and 80% resolved within 2 millimeters. So we had a very, very small range of motion. And if we go back just a few years in the literature, they're talking about 60 and 70% starting positions of the range of motion. And so what I think we could say is that we're seeing the ability to manage and control dose better in oral appliance therapy as we continue to apply more modern materials, more modern technologies, computer-aided design and engineering, but really this artificial intelligence that has allowed us to serve perhaps a broader number of patients in a more comfortable manner. I think with bulkier devices, I would have not had the same efficacy results. With bulkier devices, I would have had more discontinuation of treatment. I would have had less management of the severity of that disease, less mean disease alleviation in that population. Was it 100%? No, it was not. And if we use roughly, just to make the math easy, if we said that I had 70% efficacy and 90% adherence, that would be 63%, multiplying the adherence times the efficacy. That would be 63% of what we would call mean disease alleviation. Well, and we could ask ourselves, is it just Mark Murphy's study? Now we've been seeing a tremendous increase in trends. When we look at the 42 ABDSM papers or CACSDD plus 5 recent ProSomnus papers were out, we start to look at a trend since 1995. We've seen a dramatic increase from below 50% to now well over 60% and approaching 70% of oral appliance therapy efficacy. And I think we've seen that as we've begun to replace bulky straps, bulky rods, bulky hooks, bulky acrylic, bulky materials with slimmer, smaller designs, things that are helpful in managing and minimizing the dose so that we're finding higher efficacy in those populations. When we look at the ProSomnus data of about 539 at 67% efficacy, we find that it bumps up to a little bit higher efficacy in terms of AHI improvement. And I totally, going back to our earlier slides, not sure AHI is the right metric for us all to be using, but it's historically what we've all compared to. I'd like to look back into that data and find subjective improvements in treatment and all of those other kinds of improvements. But it's really neat to think that device design, certainly along with some other factors we'll talk about tonight, like patient selection, et cetera, titration schedules, how we modify the bite relationship, all of that comes into play to decide how dose, along with device selection and treatment choice, along with compliance, starts to work together in this gear-like effect, this matrix, to create a much more significantly improved treatment for our patients in terms of mean disease alleviation. Now, the treatment that we choose is also important because certainly we're talking primarily about oral appliance therapy tonight, so I'm not going to spend any significant time thinking through that This patient should be on CPAP. Agree. This patient should have positional therapy. I'm in. This is an Inspire patient. This is an MMA patient. This one just needs weight loss, whatever that is. I'm good with all that. But once we've corralled some of those patients and put them into our office, I want to be thinking about minimum therapeutic dose. And so patient selection is important because certain types of patients will probably do better with certain types of appliances, with certain types of titration. We find, for example, that in the States, we are stuck using a mechanical attachment hinge, like the TAP device or Hertz device between the upper and lower for patients that are covered under Medicare. That's about 20% of my patients. In some states, other insurance companies, third-party payers are mandating that we follow those same guidelines. We don't have that in Michigan much. And so for some of my friends, it's 40, 50, 60, 70% of their patient population is mandated to use that kind of mechanical hinge. And that's not necessarily the most advantageous medicine to dose the patient with. That medicine might require a larger dose on a patient. And if it's especially a Medicare population that's older, I can tell you that we've gone to a protocol, for example, that when we talk about how the patient advances, that our Medicare patients, we tend to advance most of them ourselves because they screw up the advancement so often. One side going the wrong way, the other going the right way, or they take the wrong screw off. It's a much more dexterity challenge population, following the logical sequence population. We've had much better success with the iterative advancement kind of models like the ProSomnus IA Select, or the new Evo, because there's just no mechanical parts to screw up. You look at the side of numbers. This week you're supposed to be on 0, 0, knock yourself out. Next week you go to 0, 1, then you go to 2, 0. And so we write all that out for them. And we've had incredibly good compliance with following that iterative advancement schedule. So patient selection, starting position, device selection, and treatment. So selection, severity of OSA. I still work with my physicians very intimately, and we find that for severe patients, we're almost always trying to get them to try CPAP first. I'd like them to try 100% or nearly 100%, let's say 90 or 95% efficacy treatment, which they hopefully can comply to before we come back and find that my efficacy data in a 92 or 94% for milds, 84% for moderates, but I drop way down to about 50-50 when I'm treating severes. They're just harder for us to treat with oral appliance therapy for a variety of good reasons. So the severity in a patient selection process might steer me towards different treatments and different therapies. Also different phenotypes, clenchers, grinders, temporomandibular dysfunction patients, people with less teeth, mobility, periodontitis. People, if we can identify them, who maybe have weak pharyngeal dilator muscles, people who maybe for other reasons have low arousal threshold or higher loop gain. If we can identify some of those people with breathing exercise and tests, it can start to narrow down our spectrum, and we can find ourselves phenotyping and driving the right kind of treatment to the right kind of patient. And then, of course, interesting, I delivered a device this morning on an older patient who's in that Medicare classification. And I said, "Are you excited about today?" And she said, "Yeah, I sure am." And we get it in there, and we put the device in her mouth, and she goes, "I don't like this." And I thought to myself, okay, so what do I say? And as a dentist, we often apologize for things when we're trying to treat people and things aren't going the way they like. I simply reminded her that, well, that's not a problem. If you don't like this, we can always go back and talk more about CPAP. She don't know, I love this thing. So you see, sometimes it's perspective. You know, it's I'm cold, but I'm not that cold. I'm hot, but I'm not that hot. I'm uncomfortable, but I'm not that uncomfortable. I don't like it, but I don't like it less than CPAP. And so sometimes helping the patient make the right kinds of decisions about their ability and willingness to comply. And it's always heartbreaking for me when we're treating a patient with an oral appliance and we're not getting good results, and we're trying various positions, and the patient's really compliant, no side effects, like I was telling you about on one patient, and we still can't get the AHI score down and subjective symptoms. It's heartbreaking to me. But my overall efficacy in that population is 74, let's just call it 75%. So 1 out of 4 patients, 1 out of 4, I'm not going to be successful with. There'll be more severes than any other category. I get that. In that paper, there was 19, 20, and 11 or something like that in terms of the population of that 50, 11 severes. And so, 5 or 6 of them we were successful with, and the others we weren't. And that's the nature of this particular treatment. Far better, as we see from a compliance standpoint, than we see with CPAP for sure. Starting mandibular position is important because I spend a lot of time on item 4 here on making sure the patient is comfortable. It trumps everything. I want the patient to go home that first night, like this patient this morning. I'll text her in the morning and see how she's doing. I'll ask her how she slept last night. I want her to be comfortable. She may still snore. She may still be tired. She may still have lots of AHI events and not have slept great. But man, if I add discomfort to that in the starting position, I'm screwed. So we spend a lot of time playing with a negative snore test and a positive comfort test and trying to find that mandibular position in a range of dose that's a comfortable dose for her to start at. See, we don't always think of that as a dosing activity. Different concepts we mentioned already. So again, the point is not to debate or talk about different. I am fine with somebody doing a phonetic bite, a George gauge bite, pharyngometry, airway metrics, matrix plus. Those are all excellent ways of taking the bite. You know what I'm worried about? I'm not worried about what school of thought one of those people might have about their bite relationship when they're trying to find that right three-dimensional position for the mandible. I'm worried about the atheists who don't believe in anything, who say maybe I always start them at end to end. Well, that's arbitrary. How could we start somebody in an arbitrary position? And I've heard people say to me, well, I start everybody at end to end. I go, really? Would you start me at end? They go, yeah. My maximum protrusion is end to end. I cannot get my lower incisors in front of my upper incisors to save my life. If you started me at end to end, I will hate you in the morning because I'll be so uncomfortable. And I do want us to think about not a one plane, one dimension bite relationship. At least think about 2 dimensions, but really think about adding vertical when you need it. And some people start, my good friend John Carolla, for example, starts with a lot more vertical than I do. And then he adjusts the horizontal as he needs to. I start with more of a horizontal adjustment, and I add vertical when I need to by changing out George gauges with different verticals on them. But we're both trying, I think everybody's trying to find that 3-dimensional position that's right for the patient, for the mandible. And then what's the patient's responsiveness to those different treatments and therapies? And so having something and that the patient is comfortable with and sensitive with, and it has the possibility of reducing the disease alleviation. And then device selection, and you hear me talk a lot about ProSomnus devices, and you will hear me plug them. I can't help it. I use so many devices exclusively that are ProSomnus. I do have to drift off course once in a while and use something else for a variety of reasons. But now with Evo, I'm finding a broader scope of like Bruxers or people with a lot of restorative care that that device will replace some of the printed nylons I was using. But the idea being that we've got to think about how big is their bony box? How much tongue space do they have or need? We don't want our appliance competing for tongue space. Comfort, we've got to think about strength, maintenance, replacement, repairability. There's studies, there'll be a new one coming out at the ABDSM this year that Scott Craig's repeating from 2014 with a larger database, talking about the percentage of times at delivery, the average dentist has to have an intervention with the device, an adjustment, and the average number of times that there's repair or replacement down the road. And when you factor that into the cost per hour in a dental chair in a dental sleep medicine office, that can be some of the most expensive time you ever spend. We don't think as dentists very much like a business. Scott Craig's not a dentist, he's a businessman, and so he thinks about it very differently. What about materials, biocompatibility, hygiene, maintenance, biogunk? When you dunk these things in mustard for a week, as we've done, and measure them with the colorimeter, you get different kinds of results when they're not milled, when they're not solid, when they're not denser particulars. I'd love an advancement mechanism that was monolithic, that was just part of the device. And so the iterative advancement is certainly my favorite design because I now don't have to have straps or screws or parts that can either break or stretch or difficult to keep clean. And I want to have the same precision that if I say this is the spot I want to start at for the mandible, I want to be able to send that to my manufacturer and have it come back in exactly the same spot. And we've done lots of studies showing that most manufacturers can't get within 1 millimeter. And then second, when they advance the patient, sometimes they're cattywampus or off just a little bit. I want that position held. Some of the newer screw mechanisms have been much improved with wider screws, longer threads, wider threads, so that the thread mechanisms are more engaging. And it has to fit the economics of your practice and your reimbursement mechanisms. From an advancement protocol standpoint, when we're thinking about dose, I'm always thinking about, will we advance it? Boy, I'd like not to, or will the patient advance it? And that's the beauty of that IA kind of platform, the iterative advancement is really, I haven't had a problem with patients being able to advance those or figuring out where they're at. They're very precise, very accurate, and very simple for them to do. How quickly do we advance them if we're going to advance them? And I try to give the patient a little bit of latitude in this. If it is a TMD patient, if it's a patient I think I need microtitrations on, and we're using a CALP or continuous advancement, a kind of a dorsal that we have, then yeah, then I'll want smaller than 1 millimeter, and I might want to go a little bit slower. And we did that again with that patient that we finally discontinued treatment. Now we moved her back, started over, went slowly. She still didn't do well. So usually when I run into one of those patients, when we back them up a little bit or go slower, they do really well. Should I start all of them slowly? No, I don't want it to take 10 weeks to move them 3 millimeters or 2 millimeters and find their therapeutic position. I'd like that to happen as quickly for the patient and my referring physician as possible. And then what are we going to do from the standpoint of that advancement protocol to know that we're in the right spot, that we found the sweet spot for the mandible? Certainly subjective improvements are important. I try to tell the patient, I sent her home today with a pulse oximeter, and I said, you can advance every 3 to 5, 7 days. And we wrote out the schedule. I said, don't worry about if it's 5 or 6 or 7 days, whatever you're comfortable. And then when you go forward, if you go forward a millimeter, you don't like it, go back. And then when you say to me, Mark, I'm sleeping better, I'm not snoring, I don't get up to pee as much, I feel a lot better, great. Put the pulse oximeter on for a couple of nights, drop it back off, or read the data. If that data, the objective data, matches your subjective data and observation, then I'll know we're ready for the follow-up sleep test. So this whole protocol has to fit into this dose management. With ProSomnus, I've got the advantages. When I'm looking at these, you can see the platform. That's what I really want to show here, how small the platform is, lingualist design, having a lot more room for the tongue. The new flexible Evo device over there is really kind of neat. But the idea being, I don't want to compete from a dose standpoint with the tongue for airway space. And so it's critical for me to be able to have a device that has the precision and has the aptitude to allow me to not have to increase my dose significantly. I want devices that are designed to mitigate, prevent, and have less side effects. And when I have less protrusion and bilateral symmetry, I don't have as many temporomandibular dysfunction challenges and issues. When I have a retainer-like fit, we've got a 2-year study with Gene Santucci and Nicola Varanias out of Calgary, who demonstrated for us there was no tooth movement at 2 years. We're about to repeat that at 4 years. On Evo, we do not have 2-year data yet because it's so new out. We've got that at 6 months. We've got a handful of overlays that show no tooth movement. You have to have some way of having a morning occlusal guide, morning aligner, realigner to get that patient's bite back. You want to have things like you saw on the ProSomnus herps, those little plastic buffers, if you will, little comfort bumps that help reduce the irritation that we get from those screws sometimes at the corner of the mouth. There's got to be ways that we can shape and form the parts of this so that there's more comfort. More comfort is going to mean less dose because the patient's going to be more comfortable. They're going to wear it more. Less protrusion, less force on the teeth, having redundancy in the design, being able to press a button and mill another device if we need one down the road. Those are all advantages that we have. I'd love to be able to, I'm using a lot of Evo lately, and the joke is I can grind away a little bit of Evo, but I can't add to it yet. We don't have a mechanism like we do with polymethyl methacrylate. So the advantage of PMMA is I can grind it and polish it back up, and I can add to it if I need to. So if I have to reline or a patient has a significant amount of dentistry done. But really this whole thing of a less bulky design, smaller, more tongue space, these are things that give me advantages of having less side effects. The recent study, you can see some color changes down there in the bottom. This will be available at the ABDSM meeting. I can send you a copy of some of this as soon as it's published. But the new Evo device, we specifically went out and asked the question to compare this to CPAP. So we had 32 responses, I think, from doctors in the IRB study. It was a clinical trial that was registered with the government. So it was really neat to do this, multi-center and everything. And the questions we were asking, did you like this new device better than your CPAP? And we had 22 CPAP users, I think, in the group. All of the people in the group had worn either a soft liner material or a printed nylon device. So we were also asking, and most of them had worn at least 1 or 2 devices. Some had worn as many as 8, if you can believe that. Crazy case, doctor or patient Z, they call him. But multiple devices. Did you like this new Evo material, which looks like polymethyl methacrylate, but has a little bit of flex to it and greater structural strength, about 10 times tougher, if you will, than average polymethyl methacrylate that's hand cured, cold cured. And then, of course, we wanted to make sure that it had the same stain characteristics, and we would love to have been able to say that it also causes no tooth movement. When we did the IRB, it was actually in the fall of 2020. And so we were very lucky to get such great successful data and such great preferences. And it turns out that 96% did have a strong preference of this over their previous device, and everybody preferred it over CPAP. That's no surprise at all. You'd expect that. So it's really been a fun launch of that product. Compliance is the final piece of the puzzle we'll talk about briefly. We're way short in dentistry, way short in oral appliance therapy and dental sleep medicine on objective studies. The effect study was a good one, done by a physician rather than a dentist, using our devices with a DentaTrack chip in it. And he had, I'll show you some of the summary of some of the results. He also double checked the compliance with ABDSM, which is similar to like a Fitbit kind of recorder, sleep IQ in bed. But he had overall well over 90% overall compliance, 93.6. And when you calculate that with the efficacy he had in terms of pre and post AHI scores, he ended up with a mean disease alleviation of 56%, and in the responders, 61.5. That's pretty significant numbers, and you're going to see that when we graph that out and compare it to CPAP. But you've got this hassle of this thing that looks like a vibrator for pouring up dental stone and a reader. It's just a pain in the butt. We've done some studies too with Jerry Hu, where he had 89% objective compliance. So let's call that 90% in terms of the number of days, got great results. And we've also done some with a Theramon chip where we're starting to use. The Theramon chip's a little bit smaller. It's out of Belgium. It's a really cool little chip. It gives us the same kind of information, but it takes up a little less space. We like it. And it's got a couple of different kinds of readers. It's got that same sort of a dish reader, and then it's got a pen reader. What we're waiting for, and we've seen some prototypes, which is very exciting, is where we're going to see a chip embedded in the device that is Bluetooth capable and reads right to your cell phone. And so that patient's data will upload in real time, and we'll be able to start to accumulate the kinds of numbers that they do with CPAP. See, one of the beauties of CPAP is every single one of those machines has a compliance monitor in it that uploads to the internet in real time. We don't have that yet. But when we have a $10 or a $15 or a $20 chip cost instead of a $149 chip cost for one of these compliance chips, and that's just a matter of time and space of that coming down, we'll be able to apply that kind of technology in a very useful sense. If they can put a pulse oximeter on my watch, I'm sure we're not far from being able to put a pulse oximeter and a heart rate monitor and all kinds of stuff that will give us all kinds of compliance information on those therapies. Phil Neal, I do a lot of lecturing for the United States Army. I've done a little bit for Canadian Armed Forces as well, which has been kind of fun. And he says, CPAP has great efficacy, but it chases compliance. And we have, in oral appliance therapy, he's a dentist, Colonel Neal is, we have great compliance, but we chase efficacy. And I mean, that's so true. There's this, teeter-totter kind of thing. Eddie Stahl is looking at, I think this was, how many cases of this? 100 and some cases. He's got much further data, but that's just going back in a calculable period of time where we had all the data. Well, 85 patients, I take that back, and he's got that broken down on the right, where he got incredible efficacy. And so and across mild, moderate, and severe, he's a physician. He's an ENT who's also a dentist, also an MBA. And so his premise was to say, oral appliance therapy is ready for prime time, not just for milds and moderates, but also for severes. So Eddie has been commissioned to do a study with ProSomnus on developing a group of patients that will track just doing severe indications with oral appliance therapy. And all of these kinds of data sets that we've got right now are compelling because they're at a time when you saw that AHRQ paper where we're really worried about the effectiveness of CPAP not being sufficient for a therapeutic goal. And you heard me say this earlier. So efficacy, how well the treatment works, times its compliance, gives us the mean disease alleviation or effectiveness. And that's a critical metric. In fact, you could think about the SARA index, for example. The only reason we have a SARA index, the sleep adjusted residual AHI score, is because if a patient wears a CPAP half the night, and let's say every day, and they wore it the first half of the night more likely than the second half of the night, their sleep adjusted average AHI might still be quite high. If they have an AHI of say 60, in the first part of the night, it's 20. In the second part of the night, it's, in the first part of the night, it's 40. And then in the second part of the night, it's 80. and it averages out to 60, and it's higher in the second part of the night because there's a lot more REM sleep. So if the sleep adjusted residual AHI could still be that they have an 80 for half the night, cut that in half, their sleep adjusted residual AHI score could still be 40. That means a patient could be wearing their CPAP a compliant amount of time, 4.5 hours a night, and still have severe sleep apnea. So that's why in that disease population, there was no significant change in how well they did. Back to dose again. So effectiveness graphed out. Oral appliances, man, we've got compliance kicking its butt, but we're chasing efficacy, and CPAP's the other way around. Well, let's throw in some other things. Neurostim, when you think about Inspire therapy, which by the way is not just some magical thing. They implant a thing under your chest skin over here, so you got a lump that looks like a pacemaker, and then run some wires up your neck and stick them into the base of your tongue. So that's Neurostim, and it's got a pretty good effectiveness, 48%. CPAP, 50% if you give them 90% efficacy times 56% adherence, which is probably high, by the way. MMA surgery, let's assume that the effectiveness is 85%. It might be as high as 90. I won't argue with you. Adherence is pretty good too. It's hard to move the jaw back. Most of those patients, when they bust their jaws and bring them forward, they stay there. That's probably the best treatment of all. But what about the side effects? What about the traumatic invasiveness of that surgery? That is not an easy surgery. My oral surgeon friends do not want to do that surgery on people. They would much rather have them wear an oral appliance. Legacy oral appliance therapy, when you look at those graphs we showed you earlier, we get back around that 50%. So Neurostim, oral appliance therapy, CPAP, all about the same. And it's this wrestling match between efficacy and compliance. ProSomnus, though, because of the smaller platforms, because they cheat a little bit, they mill everything out, and they're able to make them smaller and stronger, and give the tongue more space. We've got fewer side effects, better compliance, and we're able to get a little bit better efficacy, and that's starting to translate into a higher level of mean disease alleviation, adherence times efficacy, compliance times efficacy. So we're getting a higher effectiveness, and that's looking at 8 hours a night rather than 4.5 hours a night, 5 nights out of 7. So when we think about this, I would argue that already today, not down the road, today, the most effective non-invasive treatment for mild to moderate obstructive sleep apnea is ProSomnus oral appliance therapy. For severe, I'd still be able to make an argument for CPAP. I'm not saying that oral appliance therapy wouldn't work, shouldn't be considered. Of course it should. But as a first-line treatment, now it's kind of a wash, because if I've got 50% efficacy in oral appliance therapy for severes and 90% compliance, I'm around 45%. I'm right in the same bucket with those others. So maybe that's where the patient has a treatment. But I would argue the guidelines for the academies of sleep medicine and dental sleep medicine should probably drive more oral appliance therapy than less. We've also got a chance with certain types of smaller platforms like these milled platforms to have higher device efficacies, better compliance, lower dose, fewer side effects, all the kind of things that we're looking to have in oral appliance therapy when we think about dose. As we finish up the last 60 seconds or so, I'm going to tell you a very brief story about, this is my year 2000. So, oh my God, every time I show the slide, I get older and older. Look at that young man there with brown hair. So that young man there was coaching a boys and a girls cross country team at Notre Dame Prep High School in Pontiac, Michigan. And when I would coach this team, we used a program that was promoted by a guy named Jack Daniels, and not the Jack Daniels that you're drinking for Pete's sakes, but a different Jack Daniels. Is a physiologist and an exercise marathon runner, great guy. And it was about VO2 max. My girls team went to states that year. My boys team did not go to states that year. And that's the story here. The girls team went to states because I managed the dose of their exercise. In a cross-country season, you have about 15 weeks. So when the kids come to you, they've been running during the summer, and they're usually runners all the time, but you can't coach them those other times. So when you get them, you get about 15 weeks. That's called a period. You have one periodization. And during that 15 weeks, till you get to the state meet, you have just enough time in 15 weeks to beat up their bodies and their muscles, have them recover, and get to a new level of VO2 max. And that's the volume of oxygen that their body is able to carry. And it's the limiting factor for distance runners and how well they're going to run. And there's a great deal of science as to how you maximize their dose by using the minimal, maximize the outcomes by using the minimal dose of exercise at certain types to prevent their injuries And if they comply, and you've detailed each program so that Megan Schneider was running a different pace in her workouts than Carrie Geyer, than Anna Williams, than any of these girls. They were all running, and I stay in touch with all these girls today, almost all of them. They ran at different paces in their workouts. Why? Because they needed different doses to get to that next VO2 max level. And if they paid attention to dosing and compliance, we were able to execute well and get better outcomes. I say the boys team and the girls team were different because the boys team always wanted to run more. The boys team, and oftentimes their parents, felt I wasn't running them enough. And I had a scientific management program for dosing these kids, which I explained to them and their parents at the beginning of the year. But man, you're just not running enough. Coach Murphy doesn't have you working hard enough. And so the parents would encourage these kids to do more. And when they did, we saw more injuries. We saw a decrease in performance. They peaked at the wrong time, or they were too fatigued at the right time to run at their best. So that year was a story that I used from 2000 beyond to coach the next episodes of kids into being more compliant with managing their dose and exercise. And the same thing is true in oral appliance therapy. So that is my minimum therapeutic dose story that I've been weaving on the last, I didn't even know I was weaving it a couple of years ago, but certainly in the last 3 or 4 or 5 months. And so when David and I talked, we thought this would be an interesting topic to talk about. How do we manage dose? And it's so multifactorial. It's like a chess game. Talk amongst yourselves, grab a cup of coffee. We'll be back in 5.
Well, thank you very much, Mark.